Hello, everyone. This is Ali again, one of the pediatric residents at Texas Tech, El Paso. Today we'll be talking about respiratory support. So basically, as we usually do, we mention everything in the description, but I also want to tell you that this is more of a part of a 4-lecture series. Excuse me. So in this one, we'll mainly talk about the basic knowledge for an intern or a medical student if need be, but it's more of an intern or resident level that wants to know more about the basics of respiratory support. What's the high flow mechanism? How does it work? What's the difference between a bubbler and a humidifier? And then we'll talk more about the words that we use in ventilatory support. Second part of the lecture series will mainly tackle hypoxia and the different types of hypoxia, the pulse oximeter, and how to deal with hypoxic patients on the vent from the mnemonic standpoints, of course. And then 3, we'll talk about the ventilators itself. We'll talk about the different modalities of the ventilator and how to apply them. Always keep in mind that these ventilator modalities can change words itself based on the company that you're using, but basically they end up being the same if you know what the function is, what the function of the mode is. You'll see that lots of them are similar to each other, just different names and different companies and different machine. 4, we can talk about the pediatric ARDS and the new guidelines, or the revision or the second meeting that they had this year in 2023. We can also talk about neonatal ARDS, and we can talk about actual ARDS in the NICU babies and bronchopulmonary dysplasia and the severity of it. So today we'll only be talking about the basic knowledge of respiratory support. Okay? Alright. So when we're talking about respiratory support, again, we're going to go very, very back to the basics. We'll talk about if someone is coming in, for example, with a bronchiolitis, and you're putting in that coding, the billing code, and you write acute hypoxic respiratory failure, right? So you're saying hypoxic. So that means when you're looking at respiratory support, looking to support one of 2 functions of the lung, whether we are supporting oxygenation or are we supporting ventilation, right? So, and a few things to know about oxygenation and ventilation is basically what measurements are we assessing it with, right? So when we look at oxygenation, we look at the SpO2 of a patient, or we're looking about the PaO2 of the patient. That being said, it also is very much determined on the modalities that you will use, and we will say how these affect oxygenation, and it will further explain to you how these modalities or these items, basically, when you change things on the vent or you change things on anything else, we'll keep using that terminology over and over again. I'm kind of used to teaching it and learning it in a reverse way. So I want to also give credit for the NICU attendings that we have here in Texas Tech El Paso. They explained it to us in multiple times over again, different attendings, and this is more or less our collection of how it's explained in a way to me, and then a bit of different twists on it on my end. So back to it, we're saying oxygenation. So oxygen. Basically, we're measuring an SpO2 or PaO2 of a patient, and in ventilation, you're looking at the pH of the patient. Is the pH acidotic? At times in NICU, they will tell you, usually the normal is anything less than 7.35. There's some tolerability in the NICU for 7.25, for example, because they are very used to this acidotic environment and hypoxic environments in their womb. So you have that degree of 7.25, but you can know there's a ventilatory failure beyond 7.15. That being said, there's also the PCO2. And the PCO2, basically, you're telling you, oh, it's above 45 or above 60. And the cutoffs for this number basically will lead to the escalation of care and determine the severity of the oxygenation or the ventilation. Okay, so if I have a patient in either, what are these support modalities I can give them? So I'll say it this way, and then I'll explain a couple of graphs which will make sense afterwards. So I have a patient with oxygenation. What do we usually change on the vent to help with? So you'll tell you, oh, I'm changing the FiO2, the fractionated oxygen I'm giving, so the percentage I'm giving. We all know that the lowest we can give is 21%. So basically, how much more than that are we giving in general? And also the mean airway pressure. And I like to write it not like this because I've seen it written a lot. I like to write it mean airway pressure. Right, so mean airway pressure basically has an equation for it, which we will discuss. This is just throwing a structure in your brain, and then once we explain further the graphs, it will make more sense. So for oxygenation, we need to increase the FiO2, or we need to increase the mean airway pressure. And the mean airway pressure, as far as we know, is the PIP, the peak inspiratory pressures, multiplied by the I time, the inspiratory time, added to the PEEP, positive end expiratory pressure, multiplied by the expiratory time, divided by the whole breath. All right, and what about the ventilation? So in ventilation, you're looking to change the minute ventilation. And the minute ventilation is basically what? The respiratory rate, which if you increase it, help washing out PCO2, and the tidal volumes. So basically, how much volume in a single breath that you take. We need to understand from this equation that this affects both of them. Meaning that we usually will also see that if we want to help with oxygenation, we increase the I time, which is the inspiratory time. And you'll see that we increase the PEEP pressure. Or we can also increase the PIP. To help with ventilation, it will tell you we can increase the PIP, we can decrease the PEEP. Here. And honestly, the whole way that I was driven to understand all of this is this question. I asked one of my attendings to explain it to me. Why, if I decrease the PEEP, the PEEP, the positive end expiratory pressure, would I help the ventilation? Okay, which brings me to this point. So, I believe this is the curve that helped me understand lots of ventilation and understand more about how things are. That being said, think of this. This equation also explains a lot why we use the PEEP more than the PAP or I time in increasing oxygenation, because it depends on what are we multiplying things are with. We know that the E time is usually longer than the I time, and that's a ratio that we know to be usually 1 to 2. That being said, so we know if we worked with the PEEP here in this multiples, will get a higher effect on the oxygenation. Same thing with the eye time. So that being said, going back to the curves that I wanted to mention to you guys. So the curves are basically like this. So we have this curve, and you can see it on the Draeger modes on the vent, I think the second view. And this is basically the volume pressure loop curve. And it basically tells us the patient is taking a breath. So this is the inspiration. And then this patient is exhaling. So this is the expiration. That means, what is this? This is your positive end expiratory pressure. This is your peak inspiratory pressure. And this is your tidal volume. So if we come and apply this curve to this point, basically, so I have this here, the same curve again, which is volume pressure curve. And what I'm basically looking at, let's say this is a pressure of 10, 20, and 30. Let's say these are volumes of meters, like 2, 300, 400, and 500. Okay. And then we have basically a curve in between. And we'll draw that little curve that we drew already. The patient is taking inhalation. Patient is doing exhalation. And this is going to be too much. Let's say here is the 10 and this is more of a 5. So now this is a regular patient that's taking a breath, and here he's taking a PEEP of 10, he's taking a PAP of 25. This is his inspiration, this is his expiration, and this is his tidal volume. Okay. Let's say when we mentioned the respiratory support, we mentioned that when we want to improve ventilation, we need to increase the tidal volume. Okay, so when we come to increase the tidal volume, how can you do it here? You can always increase it on the vent itself, which is useful. And say you max on your tidal volumes and you want to change something else and work with the respiratory rate, which is usually the first thing you do. Think of it this way. If we are increasing the PIP for oxygenation, which is the point over here, then we're in the inspiratory capacity, we give more pressures to open up more of the lung. If we increase the PEEP, the PEEP, basically it keeps more of the lung opened at the end of the expiration, opening more of the surface area to give you more oxygenation and help increase the blood flow to these areas by keeping them open and help to decrease the VQ mismatch. That being said, when are we talking about ventilation, it tells you decrease the PEEP. So if I go down on the PEEP over here, what did I do from this set point? I increased my tidal volume without increasing the risk for the barotrauma. However, I need to be aware of how low I can go on my PEEP because I need to keep normal rations of the lung open at the end of the expiration to avoid collapse and atelectasis and give proper oxygenation as well. So here comes the fact when on the vent you have a patient that you're stuck with ventilating and you have to go down on your PEEP, which indirectly affects your tidal volume based on this curve. And you will see in these patients in this curve basically that when we're talking about different diseases and we say, oh, this is the normal lung, for example, you see that patients with fibrosis or patients with RDS, they're here. They have those high pressures in their lungs and they have very poor lung compliance. And same thing with fibrosis. But when we talk to you about asthma, you'll see that they're almost here, where they are basically obstructive lung disease. So they have high volumes restricted in there and they have their pushes in. So looking at those curves kind of help you a little bit more understand how your patient is on the vent, their lung compliance, what type of lung disease they have, whether it's obstructive or restrictive, which also is beneficial on the flow loop curves and their disposition to the left or right to tell you obstructive or restrictive lung diseases. Okay, so basically now we know that when I have a respiratory support of the patient, we know when we have oxygenation or ventilation issue, how when we are increasing, let's say, resp support, and we're having those ventilatory issues or their oxygenation issues, we understood now that I can go up on my FiO2 to help more oxygenation of the patient. I increase my PIP, or I can increase my PEEP to help with oxygenation of the patient. I can increase my I time. When it comes to my ventilation, I can increase my respiratory rate. I can help with my tidal volumes. I can lower my PEEP, which indirectly improves my tidal volumes, which basically here I'm talking about my minute ventilation, and here I'm talking about my mean airway pressure, right? So that being said, we need to understand the different modalities of respiratory support. You have that patient that comes in and you want to give them treatments. So the modalities kind of range a little bit more. So you'll have this patient that comes in with something that we can say low flow nasal cannula, even though low flow in itself is not a very accurate term, but still it's a good way to differentiate between a low flow modality versus a high flow modality. And a low flow modality is basically like a simple mask or a simple nasal cannula. These are the common ones that you'll see, and you'll see a different way of people dividing it, but people will tell you that for the fractions up to 2 liters per minute or up to 4 liters per minute, you're still on that low flow. And then you'll have that high flow modality. And the high flow is basically when you want to escalate care for a patient, and escalating this care if you want to prevent intubating that patient. You want to make sure that you give this carbon dioxide washout that helps with the high flow. It also helps with the humidity and humidification, and it helps with mucociliary clearance. Has that bad effect of waterboarding the patients at times, which I'm talking about the vapotherm. And then basically it has in some literature you'll read, it will tell you that it has some PEEP pressure. PEEP can provide PEEP pressures with the flows. But you're not mainly using it to give pressures, you're mainly using it to give flows. So when we talk about we'll talk about this first. So we'll talk about when you give a simple nasal cannula, you can give it with off the wall. And when you're giving something off the wall, it means that off the wall you're giving an FiO2 of 100%. But what is reaching the patient at the end of the nasal cannula is not. It depends on the liters per minute you're giving, but we know that the range is usually up to 24% if you're giving it in the simple nasal cannula. The higher you go and the the liters per minute, the higher the FA2 will go, just because of the disperse. Sometimes they will tell you, oh, the patient is on a bubbler. And a bubbler is basically a way that they can humidify the oxygen delivery to the patients to help decrease the breakdowns, to help decrease the irritation to the nasal mucosa. And then we'll talk about vapotherm. So when we have vapotherm, basically, the machine looks like this. That's the machine. It has a tube that comes out, hooked to a normal saline. It comes here, it asks you for the liters that you want to give the patient, ask you for the FiO2 you want to give the patient, ask you for a temperature to set. And then when it comes out, it comes as two tubes within each other, right? So you'll see that here it gives you heated and humidified air in a higher flows, which usually the equation goes to, if you give 2 liters per kg to a patient, that's the maximum that you can do. And it has shown that the more you give on that, there is no benefit in oxygenation the patient, and that you might need to escalate care to higher modality. So you'll see some guidelines tell you start with 1 liter per kg or 1.5 liters per kg, and if it doesn't work, or you need to keep increasing up the FiO2, or you're going to FiO2 above 60 for a very long time, or 100% for a short time, then you need to escalate that care that you're having. So because it's temperature, when it has the normal saline, it's a heated humidified, and these two tubings are basically like this. Here goes the oxygen, and around it is the heated normal saline that basically goes and warms up the oxygen delivery to the babies. It's really useful in the bronchiolitis babies, where you give it to them, so it helps with the secretions, gives them this good oxygen support. And you'll be able to work with it. There are some literature that will tell you it provides peak pressure, and in the NICU it is, because they're smaller babies, it can be provided peak pressures. At times it tells you, oh, it gives you 0.7 peak pressure per liter to overcome the nasopharyngeal pressures. At times it tells you it gives you a lot more than that. Some trials are done on equipment, some trials done on calipers, some trials are done on animals, and the measures were always inaccurate. So it's not an accurate way of measuring of delivering pressures per se. So you're not using it for pressures, but you know there is some pressure being given through that high flow modality. And there's more numbers to it as well. Give me a sec, because I think I have. So you'll see that some of it will say that it will give 6 to 20 centimeters of water when you're giving between 8 to 15 liters per minute. But again, it's an unreliable pressure mechanism. You cannot accurately measure it. It's not the correct way of using this modality to provide pressures. You can always jump to a CPAP machine or a BiPAP machine, an IPPV, if that's the intent of what you're wanting to deliver for that patient. All right, so now, as you can see, I am using things in a different way. So I'm using it backwards, right? Okay, so I'm using things backwards. So I started on the patient with a low flow modality, escalated it to high flow modality. Now I need to escalate it more. So you can give a patient, put the patient on CPAP. And at times you can put a patient on CPAP with pressure support. What does that mean? So basically you are taking a breath over here. CPAP is basically giving you PEEP pressures. So it gives you positive end expiratory pressures, which is basically, it will look like this on a curve. You're giving the patient, let's say 5, 10, 5, 8, 10 pressures, and what you're doing is you're helping the lung to stay open. At times you give that patient pressure support, which basically means that every time the patient takes a breath, it gives you pressure support. So let's say, I'm setting that patient at 5 of PEEP and pressure support, let's say, of 7. So every time that patient takes a breath, it gives you PEEP, and then that pressure support of 7. So it gives you a small PIP difference here, which adds to 12. Okay, so that's basically, it's like a BiPAP or an NIPPV, but giving you pressure support. You give the patients that P pressure, which is normal, and then whenever they take a breath, that gives them the extra support that they need. However, when you have a patient on BiPAP or NIPPV, more of a NICU term, PICU term, you'll see that the patient, regardless of whatever they're doing, you're setting here a PIP, you're setting here a PEEP, you're setting a respiratory rate and an FiO2. So basically you say, I need that patient to take a PEEP of 5, a PIP of 15, PIP of 15, and it will be looking in a rate of 12 and with an FiO2, let's say, of 45. So regardless of whatever the patient is doing, it's forcing that mechanism over the patient. And you'll see the CPAP, it kind of comes differently. In the CPAP, they will tell you, or you want to give that patient a RAM cannula, or you want to give them mask and prongs, or you want them on a bubble CPAP. Okay, the bubble CPAP, the good thing about it, which I always like, if you're walking past a patient on a CPAP bubbler and you don't hear it bubbling, then it's doesn't have a good seal. The mask is the one most proven to have good seal. The problem with the mask and the prongs, it's very tedious to the nursing, because whenever a patient moves, it moves and they need to readjust it, recalibrate it. A RAM, the problem with it, it does not deliver the exact pressure that you're giving. You're putting it in that patient nose. It's supposed to be giving you pressures, but those are not the accurate pressure going into that patient's lungs. At times, if they are mouth breathers or the RAM cannula does not fit exactly the nares of the patient. When it comes to BiPAP or NIPPV, it's very uncomfortable because it's basically forcing that pressure on the patients. And it was one of the good tools that you have in the back of your mind when you have that asthmatic patient that you do not want to intubate, and you want to use a modality that rescue them from intubation while you're doing your rescue medication for status asthmaticus. You can use that BiPAP to help overcoming the pressures that we have. So basically in here, then you will see that we're talking about, these are the patients that we're having. We started them on this mechanism. We're increasing the high flow, and then we're increasing it to CPAP and all of that. That being said, going back to the respiratory support that we mentioned, so when you have a vent, you'll have, it depends on what type of vent. For example, in the PICU, I've seen it say pressure flow volume. At times I've seen it in anesthesia as the volume up, the flow in the middle, and the pressures. But for example, you'll see these kind of curves where it will tell you, this patient is on this kind of pressure and it has these kind of flows, and you're giving them these volumes. So this is going to be volume, flow, and pressure. And the flow here is mainly for a trigger, and this is something that we can talk about later, which how vent can be triggered, or what's the cycle and what's the modality, and it's all about tender loving care with the trigger limitation and the cycle itself. And then here on the side, it depends on how you're setting your vent, which we will talk separately about in a separate lecture when we're talking about ventilators. But what I want you to know is in the ventilators, if we're setting something for pressures, a pressure support, which basically you're giving your patients a PIP, you're giving your patient PEEP. These are what you're controlling, aside from also the rate and the I time and the FiO2. You need to look at your tidal volume. So here it will tell you all about your tidal volumes. It will tell you about your leakage. It will tell you about your POW. It'll tell you about the actual PIP we're reaching. It will also tell you the tidal volume is either total or it tells you mLs per kg. And we're usually looking for that 3 to 5 mLs per kg. At times you'll see 5 to 8 mLs per kg. And you want to go to high volumes, you do like 10 mLs per kg. So there's always a range where you can play with. NICU is usually about 3 to 5. Older kids are usually 5 to 8. And then you'll see, or you're dealing with so when you're doing a pressure, you want to keep an eye on your volumes, for example, to read it correctly. To look at your volumes and assume, is this patient hitting the volumes I want? So that's how you will assess if your pressures are working, because we just mentioned in that pressure volume curve that these are interactive in each other. And then when it comes to your volume, the same thing. You're having a patient who is placed in SIMV or a certain volume mode, and you see that you are setting up the tidal volume, you're setting up your P pressure, you're setting your respiratory rate, your I time, your FiO2, but you're keeping an eye on your PIP. You're also keeping an eye on whatever the second view is you can see, which will give you that volume loop, that volume pressure curve, and you can see the compliance of your lung. Am I hitting those volumes with low pressures, which basically means I have good lung compliance or not. Okay, so basically this was more or less of very, very, very shallow basics about respiratory support in itself. I started it in a different way because I usually like to mention the big words first. People will see them, will see the algorithm in their eyes. What do I need to change when it's oxygenation? What do I need to change when it's ventilation? And then they realize, okay, so what do these mean and why do I use them? So then I explain the loop curve or the volume pressure curves. And then I go in depth more about the escalation of care of the pressures. And I explain more what is the PEEP, what's a PIP. And this is the kind of an I time. And then explaining after that this curve, which you will see on all of your events, and what to look for and what to get your eyes used to looking for. Usually in the next one, we usually talk about hypoxia in a very short term. What is hypoxia? What is hypoxemia? What are the different types of hypoxia? What can I do when I have a patient who's hypoxic and a vent and you're thinking it's a respiratory cause, not another cause? How to troubleshoot through it. And then we can discuss later on the ventilatory support mechanism, talking about the pediatric ARDS guidelines, the neonatal ARDS guidelines, which is somewhat similar, and then different ventilatory mode supports for BPD or pediatric ARDS. Thank you, and as I always say, if there's any misinformation that was given, or if there's a better way of kind of explaining things in the better mode, please let me know. We always can correct. We can always update, and we're learning together and from each other.